Super dupes. So, hi everyone. For those of you who don't know me, my name's Katie. My pronouns are they, them. I'm an SC2 at St George's. Going to be presenting this case of a teenager who came in with a fever. So, 13-year-old girl. So she was transferred from her local hospital to George's, basically for pyrexia of unknown origin. She had about a month's history of fever, but she'd also had 5.5 kilos weight loss in just 3 weeks, actually. So quite a significant weight loss there. Also having night sweats and also feeling very tired. So going into a bit more of the history. So when questioned, she was like, yeah, I've not really been feeling great for about 4 to 6 weeks. She'd also been feeling quite hot and having headaches. Initially, the family didn't have a thermometer, but when they got one and they began to check the temperature, and it was actually 39, so a decent temperature. She had been to see the GP, who thought it could be maybe a sinusitis or something, so gave her a course of amoxicillin. It wasn't really a significant improvement. She felt perhaps that she felt slightly less tired, but no real significant improvement in the other symptoms. So she went to her local A&E, and they basically decided to admit her, do some further investigations, started her on some broad spectrum antibiotics. Essentially, at this point, the cultures were negative. So she was discharged and completed a 9-day course of antibiotics. Unfortunately, she still continued to have persistent fevers, so the GP referred her back into her local hospital. And again, these other symptoms of lethargy, loss of appetite, and weight loss were continuing. So at this stage, there was, people were starting to get a little bit concerned about what might be going on. So, in terms of her background, she didn't have a hugely long list of medical problems, but she did have asthma, which she took an inhaler for, salbutamol inhaler. She did have a history of eczema as well. She had a febrile convulsion when she was a child, but had recovered fully from that and no further seizures. Born at term, no issues at birth really. In terms of medications, she was on tacrolimus for the eczema, Aveeno, Moliant, and as I said, salbutamol. No allergies particularly. At the time of transfer, she was started on IV ceftriaxone again. But bearing in mind she'd already had a course of this previously, and it didn't seem to help. So, in terms of differential diagnoses, what's on top of everybody's list at this stage? I think I might need to come out of this to see the chat, actually, is the only thing. Perhaps somebody could tell me what's in the chat, and then I don't have to come out of it because I don't want to risk losing the screen again.
That's fine, I can tell you.
Or feel free to speak out.
We've got tuberculosis, we've got atypical infections, or rheumatological things.
Very good, very good. Yeah. The other big one, of course, is malignancy. But certainly infective cause. I mean, this is at the end of the day a teaching session on infections. But this can be kind of a generalized kind of infection, or something a bit more localized like a UTI or an abscess or something. And indeed, inflammatory rheumatological. So things like vasculitic causes, JIA. And then actually there are some other kind of more unusual things. So things like hemophagocytic lymphohistiocytosis. I think I said that right, hopefully. But also drug-related fevers, and there are some kind of periodic fever disorders as well. So at this stage, we started doing some investigations. Oh no, sorry, I've got a slide just on her family history, social history as well. So she was originally from Pakistan, but moved over to the UK when she was 5. Paternal grandfather had been treated for pulmonary TB, they thought, and he was being treated when she was born. Mum actually was also a nurse and worked with TB patients. No other sort of TB contacts apart from that, and she had her BCG. In the UK, she was living with her parents and had 2 siblings. In terms of her mum and dad, mum had hypertension, type 2 diabetes, dad hypothyroid, so nothing too exciting there. No recent travel. On examination, so the chest was nice and clear. There was no respiratory distress, no crackles, anything like that. Normal heart sounds. She did have a palpable supraclavicular lymph node. This was non-tender. So that was obviously a little bit concerning because generally speaking, when we have that, we're kind of thinking malignancy as a big possibility. And so obviously that's something that we really need to exclude in this situation. Obviously, we know about Virchow's node or what's also called Toisier's sign. And that's this kind of supraclavicular lymph node, and it can be linked with malignancy, as I say. And it's because it's the terminal node of the thoracic duct. So it can be things like lung malignancy, but it can also be like sort of more distant metastases from things like gastric cancers. But it actually can also be linked to infections like TB, I think somebody mentioned. Interestingly, she didn't have any other significant palpable lymphadenopathy in the axilla or the groin. No hepatosplenomegaly. No particular joint issues either. And her eczema seemed to be fine. So, in terms of investigations, oh, that's not meant to go there. Never mind. So, FBC was relatively normal. She was slightly microcytic. Did have a raised ESR, but everything else wasn't particularly exciting. There was no high lymphocyte count, or indeed low. Well, 1.1 is on the lowish side, I guess. 284 LDH is kind of all right. She had a bit of an eosinophilia. I suppose that's not terribly surprising in somebody with A to B. They did see elliptocytes on the film, but no blasts. U's and E's were relatively unexciting. Liver tests, LFTs were okay as well. She had a bit of a wider screen infection screen there, as you can see, which didn't really bring anything up, apart from that she'd previously had EBV. She also had a kind of inflammatory rheumatological kind of screen as well. None of those were positive. So she went on to have some imaging, had a abdo ultrasound, and actually she was found to have quite significant para-aortic and mesenteric lymphadenopathy. So that's now we've got the palpable supraclavicular node, we've got para-aortic and mesenteric, so quite widespread lymphadenopathy there. And certainly the neck ultrasound showed that she had pathologically enlarged lymph nodes in her right supraclavicular fossa. So this is her chest x-ray. Don't know if anyone's got any particular thoughts on this, who'd like to shout anything out or comment.
Nothing in the chat.
No. Fair enough. I mean, it's not terribly exciting, is it? I mean, it looks a little bit hyperinflated, but she's somebody who's got asthma. There is certainly some kind of perihilar opacities, and it's one of those where you'd be like, is it perhaps just she's got a bit of a virally infection, or is there actually some lymphadenopathy going on there? And I suppose with this child, given that we know there's lymphadenopathy going on, we might be kind of a little bit more suspicious of the findings on the chest x-ray. I don't think this was actually formally reported, so.
Someone has said.
And then she went.
Oh, sorry. Someone has said the mediastinum looks slightly enlarged.
It does, doesn't it? Yeah, and the heart kind of looks a little bit kind of thin actually as well, doesn't it? But I don't know if this is an AP or a PA. But there's certainly it's not totally normal, is it? I think you'd want to do some further imaging, and I think maybe the lung markings do look quite a little bit more marked than normal, I think, as well. Thank you for whoever said that. So then she went on to have a CT thorax, which was a little bit more illuminating. So as you can see, there were quite a lot of lesions in the lungs. And again, further signs of lymphadenopathy as well. So it was reported as multiple lung lesions. They thought one could possibly be necrotic. And again, these findings of supraclavicular lymph nodes, mediastinal lymph nodes, retroperitoneal lymph nodes. But apart from that, nil else on the kind of organ side of things or in the abdomen, really. So, differentials. That was high on the list. I know somebody mentioned that. Disseminated TB. Still haven't totally ruled out malignancy. Obviously, in the first instance, you might be thinking of something like leukemia, lymphoma, but I don't think you can really say you've ruled out the lymphoma yet. Could be also like an immunodeficiency with a latent TB, so reactivation of TB. So what would people's next steps be? Any thoughts on what we might do now?
Maybe try to biopsy one of those nodes?
Yeah, exactly. Great suggestion. Because at the moment, we don't really know what kind of nodes are they. And actually, with a biopsy, you're going to get the histology, you're going to get a lot of information from that. So in fact, she went for a lymph node biopsy. They also did a BAL, and that's obviously quite a good test because you can send off lots of things for that. So you can send off bacterial samples, you can take samples and do something called Gene Expert, which is this fantastic kind of rapid TB test, like a machine, and you can essentially put any kind of sample into it. So you can do it with blood, you can do it with CSF, I understand you can do it with, I think, solid samples as well. I'm sure Simon will correct me if I'm wrong. And you can also, when you do a BAL, you can also take like tissue biopsies, which can be sent for histology as well. So she had actually that done at the same time under the same general anesthetic as the lymph node. And because we're thinking of either potentially like a disseminated infection or potentially a malignancy with possible metastasis, we needed to do a CNS evaluation to make sure there was no lesions there. So she had an MRI brain and ophthalmology review as well. And, again, had a workup for the immune side of things as well. So, basically, the bronchoscopy and BAL, that all went fine. They didn't see any kind of gross lesions on this when they did it. They thought the mucosa looked slightly hyperemic. That's obviously a very generic sign. She didn't have a great deal of secretions either, but they found the majority from the right upper lobe. And I think from the CT, it's difficult just to project when it's just a couple of slides, but you could see on that there was kind of a clustering of the lesions in the right upper lobe. And they sent the samples from the BAL, as I say, on the Gene Expert, and that was weakly positive. It was also sent acid-fast bacilli and also TB culture, but TB cultures and acid-fast bacilli tests, they do take a wee while, and whereas the Gene Expert is a lot quicker typically. So looking at lymph node biopsy, this found multiple epithelioid granulomas, some of which had Langerhans giant cells. I think those are also called foam cells. But no particular acute inflammation, no eosinophilia, and they found one single bacillus on the Zeal-Nielsen stain in one of the granulomas, but it was actually the PCR that came back as positive for TB, and actually there was no evidence of malignancy whatsoever. So essentially, this was found to be the biopsy was much more conclusive for a TB infection. And of course, this is what the body does, because the body cannot totally get rid of a TB infection. This is why it's very difficult to treat. So it essentially walls it off in a granuloma, and this is exactly what was found in her lymph nodes. So, final diagnosis for this child was TB with pulmonary lymph node and lymph node involvement. She did have a positive tissue culture. That obviously took a little bit more time, though. In fact, the smear in the culture from the BAL, so the bronchoalveolar lavage, was actually negative. So it just goes to show that you don't, even when you're facing kind of something like this, you don't always get positive results for everything. And it was actually the PCR and indeed the findings, the kind of typical findings from the biopsy, that really kind of clinched the diagnosis. And I should say actually that I think one of the main learning points from this case is that in many ways it was kind of like a secondary point that it was TB, because actually with that kind of widespread lymphadenopathy, particularly in the kind of supraclavicular region, you're really thinking excuse me, malignancy until proven otherwise, and actually it wasn't that, but TB is the great mimic after all. So she was commenced on her TB treatment, so rifampicin, isoniazid, pyrazinamide, and ethambutol. Subsequently, actually, she was found to be pyrazinamide resistant, so that was stopped, but she continued the other 3 medications. And as I understand it, did very, very well, was actually asymptomatic at 9 months. There was no evidence of any kind of CNS spread or anything like that. And so in the end, a really good outcome for this child. And that's the end of my side of things. I don't know if anyone had any particular questions. Simon is going to be talking a little bit more about this now.
Can I ask quickly, did they think that it was
Please.
a new infection, or that it's like reactivation from when she was younger with all those risk factors that you said?
Yeah, that's a very good point, actually, because actually she hadn't been in Pakistan for like a number of years. But then, having said that, nor did she had on the kind of immune workup, which I don't think I put the results in there. There wasn't any evidence of any underlying immunodeficiency as far as I'm aware. So actually, I'm not 100% sure. So I might pass that question to Simon, who's the PEDS ID consultant, because that is a very good point, actually. But and I don't believe there was any kind of other obvious trigger for why it might have reactivated. So yeah, good question, to be honest. Simon, I don't know if you had any other thoughts on that.
I don't actually know the patient, but I mean, the question is, where did she get the TB from? And of course, 1 in 3 of the entire world have the TB germ in them, but most people obviously don't know they've got it and are completely well with it. So it's completely plausible she picked it up in Pakistan and just had, and was infected, i.e. had latent TB, but just never knew about it. And for whatever reason, she developed TB disease at this point. Now, whether it's because she was on tacrolimus, whether it's because of some other condition, maybe it's just chance, who knows? Or the alternative, of course, is she never had it in Pakistan, she picked it up in the UK. And frankly, there's no real way of knowing that unless there's an obvious contact. If family member, in the UK had TB, or, there's some other contact, then you would probably be able to differentiate it. I mean, they can do sequencing of TB if you grow it and try and fit that into the context with other kind of local cases. So PHE do that, or UK HSA do that relatively routinely now. But that's often done in the background, and we often don't sort of find out about it. And the patient, it's not something that the patient would necessarily find out about either. But they can sort of do whole genome sequencing, and therefore then see, is this the same sequence as everybody else in the region of London, and possibly picked it up locally, or is this completely different, i.e. she could have picked it up in Pakistan 15 years ago or 10 years ago, however old she was.
And I think the one thing I do recall from looking through the notes for this patient was that I believe all of the other family members were negative, so they were screened and they were absolutely fine, because you might think that actually the mother, would have had a much higher risk because, she was literally working with TB patients. But as far as I'm aware, like, none of the other family members had it. So she was obviously just particularly unlucky or something. Super. Thank you very much.
Thank you very much, Katie. That was fantastic. I'm going to hand over now to Dr. Drysdale. Take it away.
Ooh. Thanks. Can you see the screen?
Yes, we can.
Good. You can hear me all right?
Yes.
Yep. Okay. Okay. I'll leave the camera on for the minute. If it starts getting crackly, I'll turn my camera off. But hopefully it should be all right. Okay. So I'm Simon Drysdale, one of the PEDS ID consultants at St George's. Actually, Laura, who's one of the other consultants, was supposed to do this talk and put this talk together and work with Katie on this case, but had a sort of last-minute hitch, and so I've been sort of drafted in at the last minute. So apologies if this isn't quite as smooth as if Laura had done it. Hopefully, I should be able to answer any of the questions anyway. So quiz time. So we'll start off with this question. So this case actually relates to a couple of years ago before the pandemic, but what do you think about the current situation of TB in the UK? So just, I can actually see the chat, so just put the letter as in Q, U, I, or Z, whichever one you think is the correct answer. Just wait it, and there's not too many people on here, but wait, see if one or two people at least have a stab, and then essentially it will go through some of the data to elucidate the answer, I or Z. Okay. Okay, so we've covered all of them, including a B. Interesting. So the correct answer is U. Currently less cases than ever, and actually the UK is a low incidence country. I think what Laura was trying to get at with the bottom one about COVID having had a positive impact on TB is that to some degree there was initially a reduction in cases, but actually we're seeing more kind of come out now because people sort of sat at home for a longer time with symptoms because they didn't want to come to hospital than they potentially would have done if the pandemic hadn't happened. Okay, so here's some data. So this is from the Public Health England, or now UK HSA annual TB report, which comes out roughly every year. And you can see actually cases of TB have been in decline, broadly speaking, over the last 10 years ago, from a peak of around 8,000 cases in 2010, 2011, down to half of that. So that's clearly a big positive. But you can see there's quite a significant regional disparity. So the London has the highest rate with, as you can see there, 16 per 100,000. And other bits of the country actually significantly less. So if you live in London or the southeast, you're likely to see more TB than if you live in other bits of the country. Of course, there are some areas around the country with little pockets that are higher risk. So in the sort of Midlands, Birmingham, for example, has a very big, relatively big incidence of TB relative to some of the other bits of the Midlands. Ooh. Okay. So this looks at TB notifications by where the patient was born. So one of the questions Lara put was, or comments had put was around whether most people are born in the UK or not. And you can see that still, on average, the majority of TB notifications are from people who have not been born in the UK, but actually, if anything, the kind of proportion is narrowing somewhat. And then if you look by age, there is a bit of a discrepancy between those who are the age distribution, those who are born in the UK and those who aren't. So if you're not born in the UK, actually you can see the majority of patients are around the sort of, roughly speaking, working age group, so sort of the late teens up and 50s or so, which I guess reflects the fact that people travelling to the UK from abroad are likely to be people looking for work, or younger people, asylum seekers, refugees, that sort of thing, more likely to be the sort of people in that age group rather than obviously very small children or the much older adults. So across the globe, UK, broadly speaking, has a very low incidence, see less than 10 per 100,000. Similar to the majority of other Western countries, Australia, New Zealand, North America, but clearly other bits of the world, there's a much higher incidence with a sort of peak. You see South Africa more than 500 per 100,000. So, you know, way more cases of TB than you're going to ever see in the UK. And clearly lots of Africa, big chunks of Asia and bits of South America also have pretty high incidence. Yeah, so I see on the chat someone's mentioned Greenland. So actually Greenland does have a ridiculously high rate of TB. And there was a talk on this at ESPID, so the European PEDS ID Society, not that long ago. And essentially it relates to some genetic predisposition plus the fact there's a lot of crowding in one or two of the kind of main cities or towns. And so they do have a very high incidence of TB relative to, I think, Denmark, isn't it? That is the sort of territory they're associated with. Well spotted. So age-specific kind of risk factors. So you can see what's highlighted in red here is the proportion of children at that age range that have TB, the TB germ in them, but have no disease. So 1-year-olds, 50% of children who've got the germ in them will have no disease. The corollary to that is 50% actually will be symptomatic, which is way more than actually any of the other age groups. And you can see, broadly speaking, the older you are, the higher the risk that you'll be, or the higher the likelihood you'll be asymptomatic with disease. And then it decreases a bit in the oldest children because they have a more sort of adult-centric risk. So hence you get an under 1-year-old, you know, you really, and there's concern about TB, you really need to investigate them pretty thoroughly, looking for disease relative to the older children where you won't carry out quite such necessarily investigation. Okay, so next question. Again, just put the Q, U, I, or Z, depending on which comment you think it is. What is the most common presentation of TB in children? So we've got Q and a Z, lots of Zs. Yeah, so anyone who's ever written or knows anything about MCQ type questions, the right answer is nearly always the one that's the longest or the one with the most things in it. So correct, Z is the right answer. So the Verschows node is pretty unusual for TB, as Katie alluded to, is much more common in malignancy. Night sweats, actually not that common in children with TB, broadly speaking. Lots of kids get a bit sweaty at night for a whole variety of reasons, but usually not TB. Pulmonary TB, obviously can cough, but it's not the most common. Actually, there's all these other symptoms. that are most likely. Although I see she's put cough in both, so it's a little bit of a cheat. And yes, Shay, St George's ambulatory care, very good in the chat. Okay, so this is sort of some common clinical presentations. So very much like the case Katie presented. So regular fever can be either persistent, or you get it every day. It can be sort of somewhat intermittent, where you have it for a few days and then you're off, don't have a fever for a couple of days and it comes back again. But usually it goes on for many days or weeks. Night sweats are pretty uncommon. Anorexia is pretty common. Weight loss is pretty common. Sort of fatigue, asthenia. I have to say I had to look that up, and essentially it means sort of overall, essentially it's the same thing as sort of lethargy. Malaise, infants obviously can be very non-specific with the symptoms they have, as they can with any disease basically. And if the patients are coughing, usually it's a cough that goes on for quite a while, usually for more than a couple of weeks. And whether it's dry or wet doesn't really help in working out whether or not it's TB. So again, as Katie alluded to, TB is one of those things that's also called the great mimic. So essentially it can involve every single organ. Hence we get a lot of referrals in PEDS ID from these sort of cases with children with fever or unusual symptoms that people can't work out whether sort of could this be TB, because it's very difficult to categorically rule it out. And so you can go hunting in all these various different organ systems looking for the bug. And equally, if you find someone who's got TB, even if you think it's sort of classic, let's say pulmonary TB, you do always have to worry or think about, could any of these other organs be involved, particularly if they start getting symptoms that may be indicative of that, or particularly in young infants who can't, tell you if they've got urinary symptoms or whatever quite so easily. I think this sort of nicely highlights the, as it says here, continuum of tuberculosis states versus the manifestation. So you can be exposed and have absolutely no symptoms, as we sort of talked about in the questions earlier, through to full-blown TB with all the sorts of trimmings where you will be symptomatic, and unsurprisingly your bacterial load is likely to be higher the more symptomatic you are. Generally speaking, in children, they have a pretty low bacterial load, often called porcibacillary, i.e. struggle to find the bacteria. Okay, so next question. Regarding diagnosis of TB, which of these ones is correct? I. Okay, correct. Yeah, good. Everyone's going for I, which is sort of what I've alluded to. Essentially, you really got to try and hunt the bug. So if you're worried about TB, particularly in the little ones, you really need to make every effort you can to try and find it. And these other things are, broadly speaking, wrong. Mycobacterial cultures are often negative in children. IGRA and MUN2 are, IGRA is not better than MUN2, we'll come on to that in a minute, and chest x-ray findings, we'll talk about that in a second. Here we go. So radiological abnormalities, essentially you can get everything. So here goes a nice little slide that summarises the different things you can get with TB, ranging from a tiny little lymph node with nothing else through to full-blown miliary TB and everything in between. Plus you can get cardiac involvement, so pericardial effusion. So you've always got to think about that in children as well as adults, obviously. So a normal chest X-ray or a almost normal chest X-ray doesn't totally exclude TB, unfortunately. So what about laboratory studies? What can we use those to try and help? So again, much like the patient Katie presented, full blood count's not terribly helpful. There can be some anemia, there can be some neutrophilia, there can be some monocytosis, but obviously it depends how long they've had symptoms for. Inflammatory markers can be up, down, or normal. CSF, which you wouldn't usually do unless you're obviously worried about either miliary TB or CNS disease, or in the very small ones, small children, and again, the sort of classic thing you find is lymphocytosis with really high protein, can have a high LDH and potentially a low glucose. So it's one of the things that needs to be on your list of differentials for a lymphocytic CSF, although most of the time it's probably not going to be TB. So other investigations, endoscopy or bronchoscopy. It's helpful for some cases that are atypical or difficult to diagnose, but we certainly don't do it on every child who's got TB. And you can see there chest X-ray of someone who's clearly got looks like probably hilar lymph nodes. And so if it's in a place you can't get to do a biopsy, then you might think about doing a bronchoscopy, either to get fluid from in the lungs or potentially, I mean, the adults do biopsy sort of endobronchially, which occasionally we've done in bigger children or sort of adolescents. And again, just another example of various imaging abnormalities that you can find in TB that, you know, ranging from the top left one, I think that's a node, through to sort of, again, necrotic region in the bottom sort of right one. So what about exposed children? Oh, excuse me, actively coughing. Children usually infected following some sort of exposure. Often it's a parent or someone who's in the household, or someone who, you know, they share same space with, so occasionally school children, that sort of thing, school, other children at school. So usually, or often there's a TB exposure history, but clearly not always, as in case Katie presented, it wasn't necessarily clear whether from 13 years ago that was actually the exposure that was relevant. So what about comparing TST? So that's essentially the MON2 versus the IGRA or quantiferon. So neither of them can distinguish latent TB from active disease. So they will just tell you there's the germs around, but they can't tell you whether the germ is causing any problems, if you like. They work in different ways, and so they're somewhat complementary. So in an ideal world, if they were both, you know, had zero cost and there was no downsides, you would do both of them, because you can certainly increase your sensitivity and specificity if you do both on patients. But obviously we don't live in a totally ideal world. I'll come on to some of the pros and cons of each of them. So usually we do one or the other. For pragmatic purposes, if you're doing bloods for other things, it's easy enough to take some more blood for an IGRA. It's not quite as good in the smaller kids, and so often for those we'll do the remember, it does take several weeks for immune conversion. So, you know, as soon as the germ TB bug is in you, you don't immediately have a positive test, so it takes a while. Usually these kids, you're doing it because they've got, well, sometimes you're doing it because they've got symptoms, in which case they probably had the bug for a while, and a negative test can't exclude TB. They're important things to remember. So here, some of the advantages and disadvantages of the MON2 versus the quantiferon. So I won't go through all these in detail, but one of the useful things is the MON2 will be positive if you've had the BCG recently, or if you've got an infection with non-tuberculous mycobacteria, but the quantiferon or the IGRA won't be. So it potentially can be useful in trying to differentiate between the two of non-tuberculous mycobacteria versus TB. And then you can see the other things on there. Obviously, it's a blood test, which is pretty easy to do, but it's expensive and requires a lot of equipment. For the IGRA, and the TST is much more straightforward, but does require a poke in the arm and a second visit at 48 or 72 hours by someone who knows what they're doing to be able to read it. So pros and cons of each of them. And again, I won't go into this because Lara being Spanish, obviously this is a Spanish slide, but essentially the T-spot or the quantiferon is looking for these antigens that are present in TB but not present in the BCG, and so hence it can differentiate between non-tuberculous mycobacteria, including BCG, and TB. There is a caveat that these other mycobacteria, it will also be positive. So you get a false positive with these 3 mycobacteria. So where do we get the bug from? So in an ideal world, again, we try and get at least a couple of decent samples from whichever organ we think is affected. So fairly commonly that will be the lungs. So either induced sputum for the older children, sometimes a bronchoscopy. The young kids that swallow it might be a gastric aspirate. And then obviously you can do a biopsy. You can get it in, look for TB in urine. You can look for TB in stool, in the CSF, as we've already discussed. So essentially you want to get as much sample as you can, as many as is sort of realistic, because that will increase your chance of finding TB. So AFBs, so that's essentially where you look at it under a microscope. So you get that pretty quickly, but it's not terribly specific for TB complex, and it can't differentiate between different species, but pretty good if you find it. It's highly suggestive of sort of mycobacteria. The Gene Expert, which is the PCR test, again is pretty good, but not perfect. And then the best test would be if you actually grow it, but unfortunately in children, because they don't have that many of the or have a relatively low bacterial load most of the time, it's a struggle to actually grow it. I think, as Katie alluded to, histopathology, cytopathology, you can also look for it in tissue. So you can look for caseating granuloma. Of course, there's a whole list of differentials, which we often refer back to when we get a biopsy result that shows some sort of caseating granuloma, and sometimes it's TB and sometimes it's one of these other things. So you've got to always bear these in mind. Okay, so TB treatment. Which of the following is correct? Again, if you've ever done any training on MCQs, there's always one thing that everybody should remember. Yep, if are all of these right or all of these wrong, it's nearly always the correct answer. So yep, Z is indeed the correct answer. TB infection or latent TB is treated with 6 months of INH or 3 months of dual therapy. Generally, the kids tolerate it really well, unlike adults. If you've got severe disease, miliary, TB, meningitis, resistant disease, then obviously you might need to extend the spectrum of what you treat with, and thus they're all correct. So one of the slides earlier on, we had the sort of risk of children having symptoms if they have the bug, and so risk factors for progression. Again, I'm not going to read out all of these, but ones in the bottom left are sort of relevant on a global population. Young children are more likely to have severe or to have disease rather than sort of latent infection. Obviously, if you've got a problem with your immune system or you've got HIV, then there's a much higher risk of developing TB disease. And then there's all these other various bits around. You can see that impact on that. So how do we manage TB? So the nice guideline from 4 or 5 years ago now covers this, obviously. So your active TB in the middle, do you have CNS involvement? Yes or no? If you've got CNS involvement, and that includes sort of spinal cord disease, then you get a total of 1 year of treatment. You get the standard sort of 2 months of 4 drugs, and then you get the extended 10 months of usually rifampicin and INH. Whereas if you've got no CNS involvement, then usually you go for a standard 6 months of treatment. Both cases, you get pyridoxine, which is a B vitamin, which helps reduce the risk of peripheral neuropathy that you get with isoniazid. And clearly, if you've got a drug-resistant type of TB, then you may well need to alter the regime that you're giving. Question about steroids always comes up. Who should we give steroids to reduce the risk of iris, which is sort of or TB or sort of reconstitution, immune reconstitution syndrome. So the evidence really only suggests you should use steroids in those with CNS or pericardial disease. Very occasionally it's used in those with other sort of sites of infection, pulmonary disease. They've got very significant disease or having a particular sort of immune reaction to it, but broadly speaking, just those with CNS or pericardial disease. And you start with a fairly high dose and wean it over 1 or 2 months. And again, it's usually Dex or prednisolone. So just realise I've got only a couple of minutes left. So this is the SHINE trial. So this was published fairly recently. So this was looking at whether you could reduce 6 months of treatment down to 4 months in children with sort of relatively mild disease. So this is a pretty big phase 3 randomized controlled trial. I can't remember exactly where it was carried out. I think it was South Africa. But essentially it showed that those kids with relatively mild, relatively mild disease, 4 months treatment was actually as good as 6 month treatment. So meaning you could shave off 2 months worth of antibiotic use, which is good in terms of side effects, it's good in terms of costs, good in terms of adherence, it's good in terms of antibiotic resistance. So I suspect there'll be a move to improve or getting guidance to reduce the duration of treatment, probably in the next few months or years, as long as it takes to update guidance. And I think this is the last, second to last slide. So multi-drug resistant TB obviously can be very difficult to treat. This is from I think WHO actually. So obviously it depends what type of resistances you have, but this is if you've got multi-drug resistant. Essentially you go just down the, you've got your MDR TB diagnosed, you then go, okay, so group A, these ones, how many of those can we give, either because we've got them, they're available, we can afford them, the patient will tolerate them, they've not got interactions, and we give as many of those as we can. We then move on to B and do the same thing. And then if you've not got to the stage where you've got at least 4 drugs, you start adding in some of these other ones, again, depending on availability, interactions, etc., etc. So it's really a bit of a sort of recipe mix and match. But it does mean you sort of, there's at least some guidance of what to do, because the evidence here is fairly limited. And as you can see, there's quite a lot of drug you potentially could put these kids on. I think that's all we had to say. Happy for any questions. Thank you very much.
Does anyone have any quick questions? And then we're going to move on to the MCQ quiz. Feel free to tap in if you do.
Yeah, any questions, pop them in the chat. Emma is just going to get the screen up for the quiz. It's an anonymous quiz. It's based on everything that we've been learning over the last hour. It's going to take like 5 minutes, so good opportunity to get your brains switched on and ready to go back to work for the afternoon if you're lucky enough to be at work today. So you need to go on your mobile phone or on a web browser, whatever you've got. You need to go to kahoot.it, that's KAHOOT.it, and then Emma's going to go into classic mode and a screen should come up that will give you a game pin. So everyone, I know how many people there are on this call, so there's no excuses. You can give yourself an anonymous nickname. If you want to give yourself an anonymous nickname, why don't you choose a country that has a high incidence of TB? If you'd rather everyone not know who's answering the questions, we're going to give it 30 seconds and then we'll start the quiz. Just 5 questions. You've been told all the answers today. It's just a good chance to cement it into your brain, particularly for those of you who are going to be taking exams soon. I know there's a few coming up. We've got Peru. GL, is that someone's initials, or is it Greenland? Who knows? I think that's definitely going to be one of my facts from today for some incredibly geeky pub quiz. I mean, Africa's not a country, but fine, that's okay. We're going to give it 10 more seconds. I promise it's going to be fun. For those of you who haven't done one of these before, what happens is that you get points for getting the answer right, but you will also get points for answering quickly. So as soon as you see an answer that you're happy with, choose it. All right, shall we get going? Okay, so first question of 5. Which of these, you're going to see some options, is a common feature of pediatric tuberculosis?
So you have drenching night sweats, daily fever, weekly fever, or a maculopapular rash.
Very well done. So as Simon said, although we all learn about these night sweats at medical school, that was more of an adult thing. So daily fever is a really good one for pediatrics. Okay, let's see who is doing well so far.
Oh. Greenland high on the list, followed by Peru. Now we move on to question 2. So which of these findings on
Excellent. There's everything to play for.
an FBC could indicate TB? You've got mild anemia, polycythemia, lymphocytosis, or neutropenia.
All your hematology favourites there.
So Peru is gaining on Greenland, and we'll move on to the next question. Mild anemia was the correct answer. Okay, which of these scenarios is typical for TB transmission? You've got 4 options. And you're right, everyone, full marks. Sharing a bedroom with someone coughing with pulmonary TB is absolutely the correct answer. Right, let's see whether the leaderboard has changed. Peru is still on there, number 1, highest answer streak of 3. Well done, good work. Right, next question, last 2. Which of these is a standard treatment regime for latent TB in children? And the answer is isoniazid for 6 months. Rifampicin is only for 3 months. So well done. Let's see whether this has changed the leaderboard. No, Peru is still steaming ahead. Absolutely fantastic, followed by Greenland, and then Africa is not doing so well. Next question, last one, 5 of 5. Which organ involvement in TB may require adjunct corticosteroids? Pulmonary, GI, renal, or CNS? Oh. And the answer was absolutely correct with CNS. So let's have a look at the player podium. So in third, we've got Amadine. In second, we've got Greenland. And at the very top, we have Peru. So thank you very much, everyone. Please do fill out the feedback forms.